Hi, my name is Kathleen M. Berkowitz. I'm a maternal fetal medicine specialist, and I had the opportunity to work with California Diabetes and Pregnancy Program for many, many years. I am quite honored to be able to talk with you today about the management of pre-existing diabetes in pregnancy. This will be part one of a two-part webinar. First, disclaimers is this webinar is considered as a resource. It doesn't define the standard of care, and anyone who is listening should adapt these guidelines and resources based on what their local needs are and what their patient population needs are. So don't rely solely on this. I do not have any conflicts to disclose, and so we'll move on to starting with the objectives of this presentation. The first is to identify the goals for managing diabetes during pregnancy and discover the potential complications that could affect the successful completion of the pregnancy. Second objective here, understand how to optimize pregnancy planning for both type 1 and the type 2 diabetic patient, to evaluate the comorbid conditions that so many of our patients have to deal with and the management of those during pregnancy as well, to gain awareness of the educational needs of the patient during pregnancy, and then to familiarize the learner with the use of some of the newer digital health technologies which can help you assist your patient in achieving good glycemic control. Well, at its simplest, the goal of managing diabetes in pregnancy is healthy mom and a healthy baby. I would love to see every mom being discharged with her baby in her arms after a term delivery. And to help achieve those objectives, what we want to do is prevent the mom from having complications during pregnancy. And we would like to raise enough awareness in her to prevent the occurrence of long-term medical complications. Pregnancy is a time when you have a very attentive population who is eager to learn about management of their disease, and you can translate what you teach them in pregnancy to long-term health goal success. From a healthy baby point of view, well, of course, you'd like to be born at term and not before. You would like to be born without fetal injury, and ideally, you would like not to have any time in the neonatal special care unit for metabolic complications. Again, preventing long-term medical complications is a additional goal, and there is some data saying that achieving a healthy birth weight may help a baby to have a lower risk for those long-term medical complications in the future. The complications that are common for women who have pre-existing diabetes in pregnancy include increased risks for miscarriage, for urinary tract infections, which can lead to preterm labor, for the development of preeclampsia, and for the performance of a cesarean delivery. From a fetal point of view, there are increased risks also for malformation, increased risk for stillbirth, for birth trauma, and for those neonatal metabolic complications that I discussed, such as hypoglycemia, short-term insulin, short-term requirement for oxygen supplementation, jaundice, other complications as well. We can decrease the risk of these maternal, fetal, and neonatal complications mainly by first recognizing what type of disease is present, the risk factors that led to the development of the disease, the comorbid conditions that the mom also has, to screen for those if they have not already been screened for, and to recognize that the best way to manage this is by early establishment of a multidisciplinary team approach. I simply cannot do good management without the involvement of the general OBGYN, my diabetes nurse educators, nutritionists, and endocrinologists who will help me transition care for the patient back to the non-pregnant state and long-term medical goals. You need to be able to manage diet needs, exercise needs, home glucose monitoring changes. There will be medication changes as well, including transitioning patients from oral medications to injectable medications. All of these will decrease the risk for complications to occur for mom or for baby. The other thing that's important is getting your patient to be on the same page with you for rational goals of therapy. It's not enough to simply explain to her, we want your numbers at X pre-meal and Y post-meal. If you can hook together a rational reason for why you are repeating those goals, then it's going to be very important, and she'll be able to work with you. You also need to recognize, and your patient needs to be honest with you about what barriers she may have to achieving those rational goals of therapy. So a good long conversation, bringing you together on what those rational goals are and how to achieve them, is important to accomplish early in pregnancy. Again, raising awareness that what you're teaching her during pregnancy can help her with mitigating long-term health risks is another very important goal to achieve in pregnancy time. So recognition of disease. Well, anyone with a fasting sugar of over 126 or equal to or greater than 126 is considered to have diabetes. 2-hour glucose tolerance test results greater than or equal to 200 milligrams is another diagnostic criteria that is listed by the ADA. Hemoglobin A1C greater than 6.5%. Symptoms of a hyperglycemic crisis and a random blood sugar in that setting of greater than or equal to 200 milligrams per deciliter will all help you make the diagnosis of diabetes. Now, there's a couple special situations which can make it a little less clear who has diabetes and who does not. So for patients, for instance, with sickle cell disease, who have a rapid red cell turnover, or other destructive red cell conditions, anything that's going to increase your red cell turnover is going to decrease your hemoglobin A1C values. So take that with a caveat, and so you will want, if possible, to look at more than one hemoglobin A1C, and if they were 6.7, 6.8, and 7.2 in the past, and now they're 6.4 in a patient with sickle cell disease, I don't think I would remove the diagnosis of diabetes from that sort of a situation. Recognizing disease also means characterizing what type of disease you are seeing. So type 1, of course, is usually characterized by an autoimmune destruction of beta cells. Because these patients don't have much in the way of beta cells, they're not going to be able to respond to oral medications that increase the production of insulin, because they simply don't have those beta cells anymore. Type 2 is more characterized by insulin resistance and initial high levels of insulin production. Eventually, later in type 2 disease, the beta cells undergo apoptosis, and so for many patients who are managed on oral medications in the early phases of the type 2 disease, they may eventually need insulin because of the beta cell apoptosis that occurs. It's also important to recognize pre-diabetic conditions such as impaired glucose tolerance or impaired fasting glucose. Other factors to consider are that many women don't really get a lot of care prior to pregnancy. So there is a significant prevalence of undiagnosed diabetes in the United States. The overall prevalence of diabetes in women of reproductive age in the US, most recent data through 2016, estimated that to be about 4.5%. With the prevalence of that population not knowing that they actually had the disease was 1.3%. So essentially about 1 out of every 80 women of reproductive age in the United States is walking around with diabetes but is unaware of it. In the past, we used to call this early onset gestational diabetes, with first trimester recognition of those glucose abnormalities as simply not having been substantiated prior to the pregnancy. With the more recent ADA standards of medical care, the 2020 guidelines, we've recognized that the first trimester occurrence of glucose abnormalities should be characterized as one of those conditions we already talked about. Type 1 diabetes, type 2 diabetes, glucose, fasting impaired glucose tolerance, but it should not any longer be called early onset gestational diabetes. Another popular term for a condition, maturity onset diabetes of the young, is basically a type 2 condition. And so most patients who are carrying a diagnosis of maturity onset diabetes of the young will be best characterized as behaving clinically like a type 2 patient. Now, detecting diabetes or pre-diabetes in pregnancy can rely on screening strategies. One screening strategy is test everyone. It's quite simple and can be incorporated into laboratory work that you would do and screening that you would do for any woman on the initial visit. At a minimum, however, the women that you should be testing are those with a body mass index over 25, over 23 if it's an Asian woman, and at least one of the other conditions that are listed below here. Physical inactivity is difficult because some people are active for months and then inactive for months. So this is a condition that can come and go. First degree relative with diabetes is one of the risk factors. High risk ethnic group, a prior baby over 4,000 grams, a prior pregnancy complicated by gestational diabetes, any prior hemoglobin A1C greater than 5.7%, or the existence of comorbidities, specifically things like thyroid disease or other endocrine conditions. And by the time you look through this entire list, I would say that would describe probably, 60–70% of my patients who walk in for a first visit. So again, there is some merit to using this list, but if locally you find that most of your women fit at least one or two of these extra risk factors, you may decide that you want a strategy of screening everybody at the first visit. Okay, once a woman has a diagnosis of pre-existing diabetes, preconception care should be part of every contact that she has with her care providers. All women who are planning to be pregnant should meet these preconception goals prior to achieving pregnancy. Those would include determining her baseline medical status and what medications she's using to control them, making sure those medication regimens are optimized for use in pregnancy and or breastfeeding, and undergo the screens for diabetes and hypertension, which are fairly common disorders. For all women who are preparing for pregnancy who have a pre-existing diagnosis of diabetes, good glycemic control should be achieved prior to conception. Hemoglobin A1C less than 6.5% if you're looking at the ADA guidelines, less than 6% if you're looking at the ACOG guidelines. Important to recognize, don't delay organizing the team approach to help care for this patient. One thing that you can do immediately is go through a quick review of what her current dietary regimen is. When does she wake up? Does she eat breakfast? Does she have lunch? Does she snack? Where are the barriers? So you don't need to wait for the team to approach this. The first person who has the contact with this patient should include this as part of their evaluation. Now, contraception is an important concept because poor glycemic control in that preconceptual period is associated with increased risks for both miscarriage and for malformation. good glycemic control is associated with decreased risks for these complications. About 60% of the pregnancies in the United States are unplanned, which is not a problem for a majority of women who don't have medical complications. But as you can see from the miscarriage and malformation risks, it can very much be a problem for someone with pre-existing diabetes. So I'd like to see these patients be in one of two groups: those who are planning to be pregnant or those who are planning not to be pregnant. I would ideally prefer that they not be in those 60% of women who discover a pregnancy but weren't planning for it. Those contraceptive options that you will offer to her depend a little bit on the coexisting medical complications and how long it will be until she wants to achieve pregnancy. So this graph shows you the WHO medical eligibility criteria for contraceptive use, with some common types of contraception listed, and the recommendations for whom those types would be good options and what the cautions and contraindications would be. So for instance, a patient taking a combined oral contraceptive, if your patient has vascular disease, hypertension, retinopathy, neuropathy, those are not good options for her. For a woman who is an uncomplicated type 1 or type 2 diabetic, or who has a history of gestational diabetes, those combined hormonal options would be good options. Other things to remember for LARC, pretty much the IUD and the implants are appropriate for all women with diabetes, and there's really nothing for contraindications. Same with the progesterone-only pill. The only caveat there is you really do need to take that the same day every time. Depo-Provera should be also avoided in patients with neuropathy, retinopathy, or vascular disease who also have pre-existing diabetes. Be open-minded and ask your patients open-ended questions about what they've heard about the various options. There's a lot of facts that people do understand about it. There's a lot of misconceptions that are out there as well. A couple of the common misconceptions is that the copper IUD can increase the risk for pelvic inflammatory disease. It actually does not. Another one, if I start on the birth control pill, I'm going to gain weight. Well, if you actually put populations who start the pill up against populations who don't start the pill, we all gain weight. And there's really not a lot of difference between the groups. It is true that you will see some blood glucose fluctuations with combination pills, especially in the type 1 diabetics, but it does not lead to a significant increase in your BMI. Other combined hormonal methods besides the orals is patches and rings. Those are also options as well and are good barrier methods. LARC methods, the IUD and the implants, have very high efficacy. Only issue is it may, once you stop something like Depo-Provera, it may be a while before you see the reinstitution of regular ovulation. So that's one thing to consider if your patient has a short timeline in which she wants to avoid contraception. ACOG would recommend the use of any method in a diabetic woman without vascular disease. But again, those with vascular disease or long-term diabetes should avoid the combined hormonal methods or Depo and look at one of the other options. Okay, so practicalities when your patient is in front of you for her annual visit. Childbearing age women with diabetes should be informed about the importance of achieving and maintaining as near glycemia, euglycemia as possible prior to conception and throughout pregnancy. This should be a conversation that every woman has at the time of her annual checkup with her internist, obstetrician, endocrinologist, whoever she's seeing as her primary caregiver. Preconception counseling and use of effective contraception should be presented to her as an option which will significantly decrease the risk of pregnancy complications and fetal malformation rates. And again, that should be any annual visit, any contact. Once she is in the situation where she is planning for pregnancy or you've recently discovered a pregnancy, a multidisciplinary approach is a very useful one, and many localities have this capability. Some do not. Ideally, if you're building a multidisciplinary team, if it's something that you have the resources for, having an endocrinologist on board to help these women transition in and out of pregnancy and back to long-term care is important. A maternal fetal medicine specialist who has the time to sit down with the patient and go over all of the different aspects of each trimester of pregnancy and recommended changes is important. Critical to have registered dietitian, nutritionists, and diabetes educators with the team, and the capability to screen for comorbidities and complications. Again, that may involve an internist if there are no endocrinologists or maternal fetal medicine specialists available. I don't have it on the slide, but of course, the obstetrician may or may not want to be primarily involved in the glucose management, but definitely needs to be involved in establishing the recommendations for care at various times of the pregnancy and in the discussion about timing and route of delivery. If it's one thing that COVID taught us, it's how to use virtual visits and the vast potential of uploadable programs and telephone contacts. I would urge anyone who has the capability to use these to develop sort of a script to use for each one of these types of contacts: preconception, first trimester, second trimester, third trimester, postpartum, so that you, whether the contact is a telephone contact or a virtual visit, that you've got a checklist of sorts that will help you remember to answer everything that your patient is going to need to know for that time, from the visit you are having with her now until her next visit with you. And again, uploadable devices, the ability to be able to upload your meter and have your caregiver give you almost real-time advice on what to do with it is quite good. And again, a lot of us have been able to achieve that, especially since COVID switched so much of the care to virtual visits. Don't forget the simple stuff. Everybody needs prenatal vitamins. And the difference between a prenatal vitamin and a regular vitamin is the amount of folic acid that is contained in the preparation. Now, when you're talking generally to women with diabetes about pregnancy and glucose control, there are a few things that should be discussed at each visit. So starting at puberty, preconception counseling should be incorporated into routine diabetes care for all girls of childbearing potential. That's both a recommendation from the ADA and the American College of OBGYN. Family planning should be discussed, and effective contraception should be prescribed and used until a woman is prepared and ready to become pregnant. Preconception counseling is extremely important, and again, it won't be something that your patient is going to, in most cases, make the appointment for. Yes, I see a lot of women for preconception counseling, but they usually know they've already got a problem. So again, preconception counseling should be part of an annual visit as well, and should address the importance of glycemic control as close to normal as is safely possible, ideally less than 6.5%, to reduce the risk of congenital anomalies. Those anomalies can occur even before a woman realizes she's pregnant, so the only way to minimize those risks is preconception control. If she's planning pregnancy, or she's quickly become pregnancy, we should know what's going on with her eyes. There is some risk to develop or progress with diabetic retinopathy. So if she has not had a recommended dilated eye exam, this should occur ideally before pregnancy, or if not, in the first trimester. There are no pregnancy contraindications to performing a dilated eye exam. Okay, I'm here I'm going to go through a few of the classic studies that we've seen showing how preconception control affects the risk for congenital malformations. In this slide, you see a fairly recent publication from 2019 looking at the risk of anomalies based on the preconception hemoglobin A1C. And you can see if your hemoglobin A1C is 6%, those risks are minimal. Between 6 and 6.9, you start to see some small increases compared to a hemoglobin A1C under 6. By the time in the right-hand column you get over to a hemoglobin A1C of 10% or greater, you can see that there are significant increases in all anomalies, specifically a lot of cardiac defects and central nervous system defects as well. The genitourinary and GI are a bit rarer. Again, classic studies to know about. You know, if you're reading classical English literature, you want to know who the big authors were. It's the same thing reading medical literature. And so the next couple of slides, I've got some of the classics listed here. This study by Furman looked at women who had preconception control compared to non-diabetic women and women with diabetes who had quote unquote late entry to care. And late entry to care in this study was defined as 6 to 8 weeks gestation. So you can see in the non-diabetic population, 1.4% of those women had a baby with some malformations, where the women with diabetes who had good preconception control had a malformation rate that was even lower than the non-diabetic population. Those who entered into care late, 7.5% had a baby with a major or a minor malformation. Here are, again, a list of classics and showing you that Furman's study was not the only one that showed this pattern. Again, classic studies by Steele, by Kitzmiller, by Mills, all showed the same patterns in the value of preconception care. I'm showing this slide mainly because you don't need a hemoglobin A1C to determine what the risk of a miscarriage or a malformation is. And if your patient is now anxious after you have had this talk with her and she hasn't had a hemoglobin A1C done recently, you can review and see what her fasting sugars have been. And in this slide, you can see that basically, if your fastings are in the 100 to 109 range, there are some slight increased risks in miscarriage rate and anomaly rate, but really it begins to ramp up when the average fasting sugar is over 120. And again, that is lower than the actual diagnosis of diabetes. So you can counsel based on either one of those sets of data. So preventing teratogenesis, again, preconception counseling is extremely important. Tight control will reduce the risk of congenital anomalies, especially if you've been able to achieve a hemoglobin A1C of, again, ACOG has a number of 6.0%, ADA uses a goal of 6.5%. This must be achieved safely without risking symptomatic hypoglycemia, which could lead to driving accidents and so on. Potentially teratogenic medications are another thing to look at in this preconception time, specifically looking at ACE inhibitors, ARBs, and statins. You ideally will avoid those in sexually active women of childbearing age if they are not using a secure form of contraception because of those risks. Ideally, a woman with pregestational diabetes is going to have a baseline ophthalmologic exam annually or in the first trimester. If there is evidence of active disease at that initial exam or the most recent exam, you may even need to monitor her eye findings each trimester. Again, don't forget the simple stuff. Folic acid supplementation may decrease the risk for neural tube defects and other major fetal anomalies. Should be at least 600 micrograms daily. Most prenatal vitamins will carry a 800 microgram or 1 milligram dose of folic acid, whereas most daily prenatal vitamins are 400 micrograms. That's generalities, but you'll find that's true of most major preparations. Important to classify somebody by pregestational diabetes type, and again, looking at the classics, White's classifications are the classics. There's class B, onset over the age of 20, less than 10 years duration, no vascular disease. C is a longer duration or an earlier onset, but still no vascular disease. D, very early onset, long duration, or the presence of microalbuminuria or a background retinopathy. The categories, once you've started to develop end organ changes, nephropathy, retinopathy, or cardiac disease, it does not matter how long you have been identified as having the disease or when it onset and age, you will describe these based on the complication that exists, and that's mainly to help with risk stratification. So for retinopathy, if a patient doesn't have any retinopathy at baseline, then the development of proliferative retinopathy during pregnancy is uncommon. Special caveat there, if you're rapidly trying to achieve glycemic control and someone has a baseline element of proliferative retinopathy, you may have some transient worsening of that, and you may need to monitor that. Hypertensive women should have adequate blood pressure control, but those who do not may have an increased risk of worsening retinopathy. You treat retinopathy during pregnancy by the same criteria as you treat in the non-pregnant patient, and the performance of laser therapy for retinopathy is safe to provide to the pregnant patient without any differences in recommendations compared to the non-pregnant population. For patients with nephropathy, you want a baseline 24-hour urine. The definition of nephropathy would be greater than 400 milligrams proteinuria in 24 hours or a reduced creatinine clearance. Now, many people are now getting a spot urine protein creatinine ratio, or they're getting a microalbuminuria reading. I'd rather have a little bit more definitive diagnosis for a pregnant patient, because we do have some data in pregnancy saying that those low-level spot evaluations may give variable results. Another definition for nephropathy, creatinine greater than 1.4. For patients who have nephropathy with a creatinine value of 1.5 or more, there are significantly increased risks for intrauterine fetal demise, for preterm delivery, for intrauterine growth restriction. If your patient is on dialysis, you could approach as high as 50% intrauterine fetal demise data. Again, that's older data, but it's not that old. It's from 2008. Other things to know about nephropathy, you will see worsening renal function during pregnancy as evidenced by the amount of protein that she's spilling. Her glomerular filtration rate is usually going to be higher, and so you may even see the creatinine levels drop a touch, but the proteinuria usually does get worse during pregnancy. If the serum creatinine is below 2.5, it's very unlikely that you will have acute complete renal failure. ACEs and ARBs are, of course, protective of kidney function in type 1 and type 2 diabetics, and so they are often used, but their use is contraindicated in pregnancy because of the effects on fetal renal function as early as the second trimester. Patients with coronary artery disease, older studies, again, you can see this is from '96, showed that maternal mortality rates for women who had an MI close to the time that they conceived were as high as 50%. If the patient had survived her MI, stabilized, had a period of time in which her cardiac function recovered, and became pregnant over 6 months after that, then the mortality rates in this study were lower. If the MI had occurred early in pregnancy, mortality rates in that study were over 60%. I do think we have slightly better outcomes these days, but again, it is something for any woman with coronary artery disease due to diabetes to know about before she undertakes pregnancy. Chronic hypertensives can be treated with beta blockers. Those are quite safe to use in pregnancy, and we have a lot of data on those. Calcium channel blockers, a little less data, but also safe to use in pregnancy. And the old standby, which you'll almost never see an internist be using, but we see pretty commonly in, for use in pregnancy populations, is methyldopa. It decreases the systemic vascular resistance and leads to sort of a vasodilation. It tends to work pretty well in pregnancy. Diabetic patients with coronary artery disease should have an echo and an official NYHA classification scheme performed prior to contemplating pregnancy. This is so that they know how difficult their pregnancy will be. And these women really do need their care to be centralized in a specialized multidisciplinary clinic. Again, we've got more access to these now that we've got better networks for virtual visits, and so many subspecialists have been able to increase their ability to interact with systems that they were in the past isolated from. Risk assessment. These are things that you should talk about with any diabetic woman who is contemplating pregnancy. What's her diabetes history? And what's her obstetric history? She may have things that have happened to her obstetrically that have nothing to do with her diabetes. Family pedigree will, of course, give you an idea of whether she is at risk for things like cystic fibrosis, spinal muscular atrophy, other single gene conditions. You'll be able to look at other comorbid conditions and what medications she's using for those. Again, don't forget thyroid disease, because thyroid disease, which is uncontrolled, will definitely make it harder to get good glycemic control established. Smoking and alcohol should, of course, be reviewed with every woman who is contemplating pregnancy, and the importance of glycemic control is very important in this population as well. All right, when a patient comes in and we're doing a pre-pregnancy analysis, these are the recommendations that have been developed for initial studies to perform. Comprehensive nutrition assessment should occur. Talk about what her baseline lifestyle is and what modifications she might want to consider for both nutrition, for sleep, and for exercise. You'll want to assess what her current diabetes self-management skills are so that you'll know where she can meet you for a beginning. If you're asking somebody who's never been on insulin to have an intensive regimen of surveillance and glucose monitoring, she's going to have a lower fund of knowledge to start that program than someone who's been managing a pump for the last 10 or 15 years. So you'll need to take that into account. Vitamin supplementation, again, folic acid, prenatal vitamins should be used for any woman who is contemplating conception. General medical exam, again, looking at those medical comorbidities, how well is her hypertension controlled, what is her renal status. Infectious diseases, when I originally started giving this, we talked about Zika. Well, now we're talking about COVID and vaccination status. That's beyond the scope of this lecture, but there are definitely conversations that still need to occur with your patient. Assess any risk factors she may have for congestive heart disease, and if those are present, you may want to consider an EKG or an echo. Thyroid disease very commonly coexists with diabetes, so it should be screened for. A lipid panel, not because you're going to treat with statins, but you do want to know what her baseline risks are, and that will help you with management after she completes the pregnancy. What's her baseline hemoglobin A1C? What's her renal function? And so those would be initial studies to perform. The eye exam we have already mentioned. Ideally, that will happen in the preconception period, and if it has not, it should happen in the first trimester. And then especially for patients who are having active eye disease, you should consider monitoring every trimester. For other patients, you may only need to do it annually or postpartum as indicated by that degree of retinopathy. You want to look at pregnancy-specific risks. Again, these genetic disease carrier status for things like cystic fibrosis and spinal muscular atrophy. Does she have a prior history of a classical cesarean section? Does she have a history of prior preterm birth? So you'll add those on to the evaluation of the pregnant diabetic as well. There is a checklist that SMFM has published. I've got it referenced down here at the bottom. And so you can access that online as I did a while ago. It was published in August of 2020. And it'll say at the initial visit, White's classification, get a history of diabetic complications, perform a physical exam, especially including lower extremities, looking for things like varicosities and DVTs, get a retinal exam, get that education and get yourself on the same page with what your patient's educational needs are. Glucagon kit, we'll talk about that more in a minute, lab tests, vaccines. And one of the things that I've added to this that isn't currently in the checklist, but this is actually a good time in that first trimester to talk about breastfeeding practices. Often obstetricians don't address this until the third trimester. Data shows that many women actually make their mind up in the first trimester. So this is something that should also be discussed and supported at that time. Once you get to the second trimester, make sure she's taking low-dose aspirin. We'll be talking about that more in the next set of lectures. Make sure that fetal anatomic survey gets performed, fetal echo because of the increased risk for cardiac defects. Third trimester, the checklist is going to talk about antepartum fetal surveillance. Are you using non-stress tests or biophysical profiles to help monitor for the risks of maternal preeclampsia or fetal stillbirth? Delivery planning, usually most obstetricians start talking to their patients about it in the early to mid third trimester. But this is a good time to go over glucose control plans in labor. Those will be somewhat dependent on your local abilities. And then timing and route of delivery, which is pretty well addressed in a lot of the ACOG documents. For postpartum care, we want to make sure that our checklist contains a plan for transition of care from the obstetrician, the MFM, back to the endocrinologist or the primary care provider, the internist, because that continuity will be very important. The endocrinologist who will be receiving the patient at the end of the pregnancy may find that the patient has a lot more experience and comfort now with achieving glycemic control than she may have had prior to pregnancy. Or she may have had a terribly rough time in pregnancy and be having difficulty transitioning back to her pre-pregnancy regimen. So those transitions of care should be on your checklist as well. At all times in the pregnancy, it's a team approach. Diabetes nurse educator, nutritionist, an experienced healthcare provider, coordinating the care with the primary care MD and the obstetrician. Every patient has a different educational need. And for some, it's mainly diet. For some, it's exercise. For some, it's home glucose monitoring. And for some, it's all of the above. So an education plan should be part of the team approach for every patient. Patients should also understand that a food plan is the basis on which all glycemic control rests. You can give a static dose of insulin, but if her food intake is going to vary from meal to meal, her results will vary from meal to meal. One of the things that I find most useful to help teach my patients is that the blood glucose value that they're looking at right now reflects what happened to them in the past 6 to 12 hours. And rather than looking back and making decisions about the next meal or the next snack or the next insulin dose based on that look back, help her to plan ahead. Avoid this pattern of, well, my sugar was 200, so I'm going to give myself some extra insulin and skip a meal. And then 6 hours later, she's hypoglycemic, so she is yo-yoing back and forth with some extreme variations. Teaching them how to plan ahead will help avoid that. Another thing that I have found is that the basal or long-acting insulins tend to be there all the time. And in pregnancy, you get a lot of variability pre-meal and post-meal. So having that baseline value of insulin action will occasionally be not enough protection and occasionally will be too much. So I tend to use the shorter acting ones, such as NPH twice or 3 times a day, and get them used to it prior to pregnancy. Not everybody will have this practice pattern, but I've found it using what I call the poor man's pump with short-acting insulin before meals 3 times a day and some NPH at night, maybe in the morning if you need it, actually tends to be a very effective regimen for a majority of patients. Again, rapid-acting insulins, for the same reason, may produce better postprandial control with less hypoglycemia than standard regular insulin. Now, we've got to talk about what your patient perceives as rational goals for glycemic control, because, you know, grandma has diabetes, and every time her sugar gets below 120, her doctor has told her she has to immediately drink orange juice. What's appropriate for grandma, who may be at risk for hypoglycemia and falling down and breaking her hip, is not the same as you will want to have for your pregnant patient. This is a good study. Again, it's 20 years old, but it is still a very good study. Looking at lean women who gained an average of 20 to 25 pounds of weight in pregnancy, looking at these non-diabetic women, their normal mean glucose was between 70 and 80. Their normal fastings were 56 to 60. Normal 1 hours were around 115. So in lean women without diabetes, this is normal, you know, and what you have to let your patient know is a fasting sugar of 63 isn't scary low and doesn't need a glass of orange juice. You do want to know if she's symptomatic at that, which she may be if this is a new regimen of tightened control. But again, letting her know what baseline in non-pregnant, non-diabetic pregnant women is important to give her a baseline for what you are then going to tell her is rational goals for glycemic control in pregnancy. Now, what glucose levels are associated with optimal maternal and fetal outcomes? I sure wish we knew. These are commonly used targets. Fasting blood sugar is less than 95, 1 hour is less than 140, 2 hours less than 120, and they're the ones that you'll find in the most recent ADA guideline. Now, there's data on both sides, and what's important for this is to remember that regardless of what you choose for what your team chooses to use for targets, you want to avoid hypoglycemia. Hemoglobin A1C is less than 6% is a nice long-term assessment of glycemic control, but again, because of red cell turnover in pregnancy, it's less useful in the 2nd and 3rd trimester. If you look at those goals that the ADA recommends, and then look at what it would average out to on the patient's meter, you probably see something like a 14-day average glucose of around 110. And then you would know that your patient was probably meeting those milestones that I had on the prior slide. What I would recommend when you get your team together is recognize that there are 3 categories of patients. Those whose fasting and post-meal values are absolutely in a range where the majority of studies show very low complication rates. Those patients whose values are absolutely in a range where the complication rates are increased, and those that fall into a middle ground where some studies will show benefits for tighter control and some studies will show no benefit. And recognizing that one of the best studies that out there, the hyperglycemia and pregnancy outcome study, or HAPO study, shows that the rates of complications for gestational diabetes increased in a continuous fashion. So it was really hard to define a specific best number for control. What I would recommend is bring your team together. Some people may want your patients to achieve fastings under 90. Some may be happy with 95s. Some people may want 1 hour. Some people may advocate 2 hours. There is room in the tent for everyone, but the team should come together with what they all want to present to the patient so that the patient is getting a consistent message from her entire team. Other things that are neat little bells and whistles that we have more available these days are diabetes technology has advanced a lot in the last decade. There's a couple of different categories of devices. Devices designed to improve accuracy and ease of monitoring glucose levels, Dexcoms and things like that. They do improve hemoglobin A1C levels in pregnancy. They may improve neonatal outcomes. Again, there are a couple of studies showing that. The other category of device is a device designed to improve insulin delivery regimens. Those would be insulin pumps. And then, of course, you've got systems that combine pumps and Dexcom sensors, for instance. So all of those are newer technologies. They really do improve a patient's compliance with her medication and her ability to assess her own response to the combination of insulin and glucose action from meal to meal. Another group is devices designed to support self-monitoring behaviors and medical oversight of glucose control. Again, COVID has taught us a lot about being able to communicate with our patients virtually and extending our ability to care for them into their home. There are some of the apps that are HIPAA compliant. This is not a comprehensive list, but again, if you are going to be doing this, you do want to make sure that you're going to be doing it in a HIPAA compliant fashion. And again, as you have expanded capabilities in many places for virtual visits, I have found that being able to do a quick 10 or 15-minute virtual visit once a week when my patient doesn't have to drive 30 miles to see me and find childcare because I can't let her child into my office because of COVID restrictions, significantly increases our ability to interact with our patients and has made my office more aware of the need that for us to be able to upload their monitoring values. I think I can conclude with that note at this time. We will be continuing the management of pre-existing diabetes, and we'll move into actual pregnant patients in part 2. Thank you very much.